Hello, good evening. Olivia's here and I'm here. We're both here. Hello, everyone. 7 o'clock. It's time. It's that time of the week where I will be doing my thing. If you've got questions, then please chip in by all means. And if you haven't got questions, we've got some pre-scheduled ones. And yes, Olivia, we got a lot. We've got 14 questions. So that is great. Looking forward to that. And if anything else comes up during the time, I'll be happy to answer those. The more the merrier, as far as I'm concerned. I'm Jonathan Staiano, consultant plastic surgeon, and I put this out as a podcast every week called the Staiano Clinic. So please do you subscribe? Yeah, you do subscribe to podcasts. Please subscribe to my podcast and my YouTube channel as well. I think we put this on YouTube, and I think we chunk it up as well. So each, questions, if there's a relevant question, then we can just put that as a little snippet on YouTube. So that's me. So we got some questions here. It's good to see you. Yeah, thank you, Olivia. Nice to see you too. We're going to kick off with this question here. I watch your YouTube. That's what we like. And wanted to ask if you have a donut lift with implants. Is there a limitation on implant size? Not really. Well, yeah. Well, there's always a limitation on implant size because of the dimensions of your frame and your chest, particularly the width. The width is probably, I would say, the most important dimension that we need to respect when choosing an implant. So that will limit the volume of implant you have. The width of your chest will limit the width of the implant that you can have. And then once you've got the width of the implant, then you can get different shapes and profiles. So there's that. So there's a physical limitation on the dimensions of the implant you can have regardless of the lift. The fact that you're having a lift means that you have got to be a bit more careful in terms of wound healing, because one of the risks of having a lift and implants is you can get wound healing problems. And if you get wound healing problems when you've got an implant in, if you get a bit of infection, then the implant needs to be removed. Now, I've got to say a donut lift has got less of a risk in a way because there's less scarring, just a scar around the nipple, which is good. The other types of lifts have either a scar on the nipple and a vertical scar, which is the lollipop lift, or a lollipop plus a horizontal scar, which is the inverted T or anchor. So the other types of lift have got more scarring, and whenever you've got a junction of scarring, there's more risk of wound healing problems. So that's a good thing about the lollipop. About the donut, a bad thing about the donut is that you have to ruck in the skin, which you don't have to do with the other types of lift because you're making a big circle into a small circle, and so you can get healing problems there. But bottom line, you've got to be a bit careful with combining a lift and implants because there could be healing problems and infection, and that would potentially mean the implant needs to be removed. But in terms of limitation on size, the question sort of maybe asking if you weren't having the donut lift, then would you be able to have a bigger implant? No, you could have the same size implant regardless of whether or not you're having a lift. But you just got to be a bit careful about wound healing problems with the lift. So yeah, there's, well, I won't say there's no limitation on size. It's not no extra limitation on size due to the donut lift. There is a limitation of size anyway on everybody because of the dimensions. What we got going on here, Natalie, is that clapping? I think that's clapping. I know this being a tiny frame, you gave the best advice. Glad I listened. Oh, there you go. Look at that. We've got a live comment backing me up on that. Thanks, Natalie. Yeah, you've got to be really careful because people come in and say, I've been on the internet and I want a 300cc implant or something. And that might suit somebody else, but it might not suit you. So you've got to look at the dimensions that you have and choose an implant that fits your frame. And that's what it's all about. That's why a consultation is important. And we're limited as to how much information we can give on the internet. People put on these forums saying, what's implants right for me? Should I have this implant or that implant? It's really hard to say without measuring your dimensions and looking at what you want to achieve, the shape of your breast, etc. So Natalie is saying hi, and JJ is saying hi right back. There you go. Hi, Natalie. Right. This is a big one. Don't know. How do implant brands such as Mentor, Nagor, Motiva differ? I think that is a really good question. I can imagine if I wanted implants, I would want to know that answer to that question too, because there are quite a lot of different makes of implants, and it can be a bit daunting. I've just been to the meeting, the BARPS meeting, and there's all these implant manufacturers there with their stands trying to say that they're the best, or why their implants so good. Do you know what I think they do differ, no question about it. They do differ, but I don't think personally, I don't think you need to worry too much about it as long as you go with one of the big reputable companies um, with a sort of track record. Um, well, I say that, but then Allergan had the thing, didn't they, recently? I mean, I think. Well, I'll tell you how they differ, but the main thing I'd like to say is that you're not going to notice by looking whether someone's got Nagor or Mentor or Motiva or a certain make of implant in. You can't tell by looking. So the look is not really going to, look is not going to differ. The reason to choose a certain make is, for me, I to be honest, I usually just use the make that I've been using for many years. I use Nagor implants because I've been using them for many years. I know the range. I know the catalog, so it's just easy for me. But I always say to people, I'm not tied to any manufacturer. So if you want a certain manufacturer, that's fine. As long as the hospital can get it, we can use that implant. So if you want a Mentor implant or whatever, we can use that implant. Um, the main ways they differ in the way they do their texturing. So there's obviously textured and smooth implants. So there's different texturing and different levels of texturing. And they used to be smooth and textured. Nowadays, what with ALCL, which seems to be associated with the texturing of the implants, they're bringing out new ranges which are sort of less textured. So they're not quite smooth, but they're not as rough as classical textured, um, um, nano textured. They're called they're just sort of slightly rough, trying to be more like smooth implants. But a lot of companies now make these nano um, textured implants. They also, the other big way they differ is in the warranty. The warranty is different between different implants, and that is a minefield in itself. So they pretty much, most of them, I don't really know about Motiva. Motiva are a bit newer. Don't really know about Motiva that much. I know Mentor and Nagor, Polytech. Those are the ones that I'm familiar with. But the warranty, broadly speaking, is different between different companies. Most of them, certainly the ones that we tend to use commonly, have got a warranty against rupture, lifetime warranty against rupture. That's I won't say standard, but that's quite common. So you've got to be a bit careful if someone says, "Oh, these implants got lifetime warranty." You don't have to worry about it. It's absolutely fine, because that might just be a lifetime warranty against rupture, which rupture can happen, but it's less common than capsular contracture. So that's the other problem. So some implants will cover capsular contracture, or some warranties will cover capsular contracture, some won't, and some will maybe cover capsular contracture for a limited period of time. So that's the first thing you've got to look at in the warranty. The other thing with the warranty is some will cover you having the opposite implant changed. So if you have a problem with one implant, if you've had the implant, we've got this at the moment, you've got an implant who's been in 10, 15 years, and they say, "Oh yeah, we'll give you a new implant," you're going to be like, "Yeah, but I want them both changed because I don't want to have a 15 year I'm not going to leave my 15-year-old implant in." So some will cover both implants, some won't. Some will cover a size change, some won't. um some will just give you the same implant that you've got. So oh yeah, and some will give you money. Some will give you money towards the hospital costs, and some won't. So those are the differences in terms of warranty, um, and so basically warranty and texturing, I guess. So these nano textured ones have been brought in. Not sure how to feel about the nano texturing myself. Well, I do know how I feel about it. I mean, I think there's smooth and there's textured, and textured is better than smooth for certain reasons. Capsular contracture, stability. Smooth is better than textured for some reasons, mainly ALCL. ALCL a lot less likely with smooth. So there's good things and bad things about both. They've made the nano texturing trying to make it a best of both. I think they're trying to imply it's going to be a best of both worlds, but it could also be thought of as a, worst of both worlds. If the texturing is good, then surely less texturing is less good. If the smooth is good, surely a bit rough is less good. So that makes sense. So I don't know about the nano texture thing, but that's what it is. So yeah, texturing might be different. The way they texture the implants can be different, but as I say, as a patient, I wouldn't worry about that. The way they make the implants might be different. So it's mainly the warranty and the texturing. God, I answered that very well. It's a problem with live. If I could do that again, I'd probably do that again. But anyway, we're in it now. There's no turning back. It's out there. It's out there. I've let it go. So that was the answer to that question. Oh dear, oh dear, oh dear. Olivia's saying you can't be a good consultation. Olivia, I'm 100% with you on that one. Says hello, and so does Amanda Lou. Hello, everyone. Nice to hear you and see you. Could argue I can't hear you. Dear, oh dear. Right. Can't see you either. But anyway, nice to see your comments. That's what it's nice to see. Thank you for commenting. Right. Let's see if we can do better on this one. Come on, man. Surely you can answer this one better than that last one. Right. Why does the price of cyst removal differ in price? In price written twice. Oh, who writes these? Who writes these? Oh, why does the price of cyst removal differ in different clinics? We'll just say that, shall we? Yeah, I mean, we can open that up, can't we? To cyst removal, mole removal, breast augmentation, probably. Well, not probably. It is, isn't it? But cyst removal definitely, and mole removal, I think the price does differ. I know the price does differ, and I can tell you why. For several reasons. One reason, I've done a blog post about this, haven't I? Cost of mole removal. Yeah, I've done one reason. Who is the practitioner, if you like. So particularly with cysts and moles, lots of people will offer the service. Some will be surgically trained, some won't be surgically trained. You'll get different levels of training. You get people who've got no surgical training at all doing it, GPs, for instance, dermatologists, although dermatologists have done a lot of skin surgery. They do skin surgery, but it's not a surgical specialty per se. So certainly if you had a bigger lesion in a difficult area of your face, maybe a person who's surgically trained would be better, i.e. a surgeon, which could be a plastic surgeon, a general surgeon, ENT surgeon. There's lots of different types of surgeons that do it. So the training and the qualifications of the practitioner will differ in different clinics. The facilities of the clinics will differ. Now, on one extreme, you've got the hospitals where they have fully fledged operating theatres, and you may end up paying for an operating theatre you don't need. So that's why you often find the hospitals are very expensive for these things, because the operating theatre could be used to do open heart surgery or spine surgery or big major operations. So it's an expensive theatre to run. So those costs are passed on. Whereas something like this mole or a cyst doesn't have to be performed in a big theatre. It can be performed in a smaller local anaesthetic theatre. But again, there's different levels of facility there where people do it. I mean, you could potentially do it in a consulting room in a GP practice. So the higher level of cleanliness and infection control or what have you, the more overhead in the facility. So I don't think you need to go to it's a hospital. There's nothing bad about it. It's good to go to a hospital for it if you want, but you might pay more for it. So maybe a clinic makes it sound like I'm plugging my own thing there, doesn't it? Because I've got a clinic. But anyway, hostels are good as well, but the hostels are very expensive. But clinic with an operating suite, I don't know, like maybe mine. Oh dear, I'm not trying to plug myself, but anyway. But you want an operating, it's nice to have an operating room rather than doing it in a consulting room, unless it's a small thing. But the CQC sort of did they say that to us? Maybe they didn't say that to us, but we said we wouldn't really, we don't really do anything in the consulting rooms. We do everything in the operating room because it's got special floor and special lighting and special airflow and stuff like that, sterility and things. So I don't know. I mean, I don't even know whether a cheaper clinic would have less facilities. I don't even know, to be honest with you. I should go and have a look at them. But those are the things I'd be looking for. Maybe a dedicated operating room, level of the surgeon, of expertise, and finally, histology is another big area that we have. It's a big cost. So I hear about people doing moles and cysts for like £300, and I heard someone the other day £250 for a cyst. Now, histology for us is about 100 and it's nearly £150. I think it's 120 or £130 for histology. That's just histology. Never mind the packs that we open, the equipment that we use. We often use bipolar diathermy, which is a little machine, the little buzzy machine. That's a disposable thing. That's £20. The kit, the nurse, the surgery, the overhead, the consumables. So there is a lot of costs involved. And histology is a big one. Now, some places might not do histology. Now, you might not need histology, which is good. But certainly, if you did want histology, if you did want them to look at it under a microscope to give you then a report to say what it was, so it was a sebaceous cyst or a benign mole, then that is expensive. So that's another differentiator. You've got to look to see if histology is included or not. So I think those are the three areas really: the training and the qualification of the practitioner, the facilities, the level of facilities that are being operated on and whether or not histology is involved. So Olivia says you're doing great. Thanks, Olivia, for that. Thanks for that support. Olivia had a cyst done in a clinic under local, guys. So there you go. I have no problem with you advertising your skills. Oh dear, yeah, I wasn't trying to. I'm not. Yeah. Right, let's move on. Next one. Next. Thank you all. Does an inner thigh lift also help to tighten the outer thigh? I think I've lost more weight and I'm shriveling daily. Okay. I always try and be really careful in what I sort of promise, or at least maybe promise is a strong word. What I say can be achieved with surgery, and an inner thigh lift, really the focus of the pull and the sort of epicenter of the pull and the tightening is the inner thigh. To be honest with you, the outer thigh lift often doesn't have as much lax skin as the inner thigh. That's why the outer thigh you can often treat with liposuction. Doesn't sound like you need liposuction if you're losing weight, but liposuction is often good for the outer thigh because it's often not a skin problem as much as it is in the inner thigh. The laxity of the skin is less with the inner thigh. So when you lose weight, you get this sort of redundant skin, whereas the outer thigh tends to recoil better. So having sort of laxity in the outer thigh is usually less of a problem. And really the pull of an inner thigh lift is in the inner thigh. So I wouldn't say that it will have a dramatic effect on the outer thigh. The sort of vector of pull, the amount of pull that is going to translate to the outer thigh is going to be less once you've, the focus is on the inner thigh. If you maybe pinch your inner thigh yourself, and then feel how taut the outer thigh gets, I don't think it will give a sustained, significant tightening of the outer thigh. I don't think. I think if you, and one of these things is all about being prepared for what could be achieved with surgery, so you can make an informed decision whether to have it or not. So it's great to ask these sorts of questions because you've got to be thinking, hold on a minute, I really don't like my outer thigh. I'm not going to be happy if it doesn't do anything to my outer thigh. And then maybe you need to think about something else for that. But I think an inner thigh lift would really be focusing on tightening out that skin on the inner thigh, and it may not give a significant difference to your outer thigh. To be brutally honest, to be frank, if you don't mind me being frank for a moment there. After weight loss, what can be done to improve excess skin around the buttocks? A Brazilian butt lift can't be done in the UK and is a dangerous procedure, But after a big weight loss, there's loose skin and sagging on the bum. What can be done to improve it? Good question. Tricky, isn't it, when we say, oh, well, we're not going to do this surgery, and they're like, what are we going to do? We had a big discussion about it at the BARPS meeting, like, oh, you know, what are we going to do if we say we're not going to do these Brazilian butt lifts? Now, I've got to say, this has never really been my area, to be honest with you. So there was a debate, there was a discussion, and I've got a view on it, but I didn't really want to put too much of my oar in because it's not really my specialty. It's not really my field of interest. The contouring of the buttock, it is a sort of specialist thing in its own right. So if you do, and it really would have to be significant weight loss. If you've got a significant weight loss and you've got a significant deflated buttock, I guess broadly speaking, two options. In the absence of it giving volume to it, in the absence of building it up, which is the fat grafting, which is the Brazilian butt lift, which everyone's up in arms about, and implants, which also have got their issues, although some people say, oh, they're great. But if you're not going to give volume to the buttock to fill that empty skin, the other option is to tighten the skin, is to remove the skin. And if you tighten and remove the skin, then you're left with a scar in the buttock crease. And a bit like the breast, you have to make a nice buttock crease. It's a very important landmark where the posterior thigh meets the buttock. It's a sort of crisp landmark, like the inframammary fold of the breast, which is an important landmark to get right. And it's not a great place for a scar. Can you imagine it? You're sitting on it all the time. So it's not a great place for a scar. Potential for wound healing. I'm going to talk about that in a minute with the brachioplasty question, but it's not a really, it's a good place in terms of the aesthetics of it because it heals well, but it's a difficult place to get healed. So that's not a great, it's not a great operation. So I said there's two options. So in the absence of adding volume to the buttock, you either take the skin away, which is the thing that I'm talking about with the scar, or you accept it and you just say, look, have a big hoo-ha about the buttock lift. It may not be around all the time. The band, they may well say, oh, look, there are a lot of sort of research, if you like, about where we should be injecting the fat to stay safe and how all the problems occurred, and whether there's things we can do. Certainly the people who do it a lot say, look, there are things we can do to make it a safe procedure. And I think the UK standpoint is a bit like unsure about it still, but I think that it may well be something that is offered at some point. So maybe to sort of hang on in there. But yeah, it's a tricky one, and I take your point that it is tricky to know what to do in terms of contouring the buttock is a difficult one at this point in time. And yes, Olivia, we may have to just accept it. I think that's a definite possibility. And Olivia wouldn't have the Brazilian. No, I don't think I would either, Olivia. Maybe I'm not the target market for it anyway. Can anesthesia have an effect on the tongue? How can one damage the tongue during anesthesia? I've got a red mark that's not really changing. I forgot to mention, should I be worried? I've been gargling salt water. Okay, so yes. I mean, obviously, when you have an anesthetic, things go in your mouth. There's two types of tubes you can have. You can have a laryngeal mask, which is a floppy thing that goes in your mouth, or you can have an endotracheal tube, which is a more secure way of securing your airway. And when you do the endotracheal tube, they put a metal thing called a laryngoscope in your mouth to open up your airway, so they can put this tube down. And that metal thing could potentially damage your tongue, bruise your tongue, or damage your tongue, also your teeth. The anaesthetists are very worried about your teeth. So yes, totally not outside the realms of possibility that your tongue could be damaged with anesthesia. And if you've got a red mark, and also, is it painful? It doesn't say whether it's painful, but if it's painful, then it probably is something, and you've just had surgery, then it's probably something to do with the surgery. I wouldn't necessarily think it's anything to worry about. I think you, oh, I said you've seen the dentist. Okay, well, you could mention it to your surgeon, and certainly it's something as a surgeon, we would probably want to know, just because if the anaesthetist needs to know if there's been something like that, some bruising, which we wouldn't expect. So you wouldn't expect to have a damaged tongue. So something we'd want to know, to flag up and say, look, guys, was there something we did? Were we a bit rough with the putting the tube in, or was there a problem there? What's going on? Because we shouldn't really be causing bruising in areas like that, but it's something that could potentially happen. So I wouldn't worry about it, is the bottom line, too much, and hopefully it'll get better as quickly as it came. Squats, one word comment, squats. That's what I'm talking about. That's what I'm planning on doing, Olivia. I'm doing the squats. I'm not doing the Brazilian butt lift. Yeah, I'm with you on that one. This is a good one. Can't believe we hadn't had this one before. I don't think we have had it before. What's the typical time between first consultation and surgery? So there's a minimum time. Well, hold on a minute. Depends on what operation it is. Because if it's like a minor operation, like a mole or a cyst or a local anaesthetic case, we actually do it on the same day as a consultation. It's like a see and treat clinic, because often people know they've got a mole or a cyst that they want to have removed. So we do offer a see and treat clinic for those things, where you have it done on the same time as consultation. I'm assuming this question is talking about more of the bigger things, like the tummy tucks and the breast augmentations, breast reductions, the bigger operations that are done in the hospital. And for those operations, there's a 2-week cooling off period, a bit like when you get a credit card. So we can't do it within 2 weeks. So I guess that's the minimum time. But it also depends on the schedule and your life and things. And I probably wouldn't recommend having it within 2 weeks. I think you need to give yourself some time to have a think about things, particularly if it's a first consultation. So you might have been to lots of consultations with other people, but if it is your first one, you need to give yourself plenty of time. I would say the typical time is a couple of months. I would say it's typical. 2 months is sort of 2 to 3 months is sort of normal. Obviously, we've got to look at our waiting list as well. But it can be years, literally years. In fact, I operate on someone, when was it? Today? Yesterday, who I saw years ago. First saw her years ago, and then saw her again, a few months ago. So that happens, not infrequently. You see someone, and life gets in the way. They might have children. They might put on weight. They might not be able to lose the weight they wanted to lose, or whatever, and then years later they come back and they say, right, I'm ready for surgery now. So there's no sort of upper time limit. Lower time limit is 2 weeks. Classic would be 2 months, I would say, is the sort of standard. Hold on a minute, what's going on here? Olivia, me too, though not started yet. Oh, yeah, I've not started yet either. The squats, I think. Me neither. I got a bum like 2 empty pita breads. Not a good look. Thanks. Good description there, Corinna. Thank you for that. Yeah, I think we just have to stick with our pita breads at the moment, Corinna, and maybe we'll got a bit of space there. Do a bit of squats after this. Get started. No time like the present. Do you have any credit options for surgery? Yes, we do. So the surgery that we do in the hospitals, the hospital offer 0% finance for a year. One's 10 months, I think one's a year. Some people say, oh, can I extend it? I don't think, I don't think they certainly won't extend the 0%. Obviously, if you extend it, then you're going to have to pay a charge on that. But if it was me, and I should have a disclaimer, I'm not a financial advisor. Please don't take financial advice from me. I'm the last person you want to take financial advice from. But if it was me, and even if you've got the money, I would say if they're doing 0% finance, why don't you do it on 0% finance? And if you've got the money, that's fine. Do it on 0% and then pay it off at the end. I was going to say, I don't know how the 0% finance works. Actually, I haven't thought this through. I don't know how the 0% finance works. Presumably they divide it by 10. Because I was going to say at the end of the 12 months, take a loan for what's left, but maybe there's nothing left. Maybe they just divide it by 12. that doesn't work. Yeah. Anyway, they do 0% finance, the hospitals, both of them, and it is 12 months or 10 months. Ooh, what's going on? Right. Start in a minute. Yeah, go for it, Olivia. I'm going to start in a minute as well. Right. I've been advised that liposuction will get rid of one of my chins. Will I have excess skin there? How does it work? Will I have excess skin there? So yes. So the thing about liposuction is fantastic. It's one of my favorite things to do. I don't do it very often though. I was just doing it yesterday, and I just really do enjoy doing liposuction. But one of the limitations of liposuction is that it only removes fat and it doesn't remove skin. And so there are certain areas where liposuction is really good. Outer thigh, as I said earlier, hips, flanks, chest, bra roll, sort of lateral chest wall. Certain areas where it's not quite so good. Inner thigh, central abdomen, arms, because the skin doesn't recoil quite so well. So that is a limitation of liposuction. It doesn't remove skin. You're relying on that skin to recoil. So it depends on how much skin you've got on your chin. So if it is a common place to have liposuction, the chin. I don't do this, disclaimer, I don't do this sort of stuff, but I can give you broad advice. So it is a common place for to have liposuction on your chin, and often the skin will recoil by getting rid of the fullness there and the fat in that area, and that will get rid of your chin, your extra chin. If you have a lot of skin there, if you have very crepey skin, sort of thin skin, lax skin, if you have not really looked after your skin, so if you're a smoker, if you have a lot of sun exposure, then there might be a worry that that skin won't recoil. But I would say the sort of mainstay of treatment is to get rid of that fat with liposuction, because the beauty of liposuction is the scarring is hidden really. You can't really see the scar. Once you start cutting out skin, then you start getting into scars. And you've got the chin there. It's quite hard to hide scars. You can make a scar here to hide it. Probably the best thing is to have a sort of facelift and pull the scar up into your neck, up into behind your ear, and that will sort of tighten the skin of your face and your neck and hides the scar up here. But then obviously that's quite a big operation, a facelift. You might not be there yet. But this is something where you need to talk to your surgeon. And if they feel, it looks like they do feel that liposuction might help, then yes, it might help. You have to be, like I said earlier, aware of the limitations of it, so that you can decide whether it's right for you and whether it's going to give you the result that you want, which is, after all, what we're all always after. Right, another one. Oh, look, got another facial one here. Since rhinoplasty 18 months ago, my nose is running non-stop. Can anything be done about this? Right, well, this is, I should have looked this one up. This is a bit out of my expertise. Rhinoplasty is not something that I do, but in general terms, the rose constantly running is a sign of sort of inflammation. There's something there causing a bit of inflammation. Your nose produces mucus, produces fluid normally, and it normally sort of runs and goes down the back of your throat and you don't even notice it. But if there's more of it than normal, you might notice it, and it can run out here or it can run down the back of your throat. Postnasal drip it's called, but you can get a sense of more, nose running more due to inflammation. And certainly surgery is an inflammatory process, so surgery makes things inflamed. So it's not unusual to get this after surgery. I've got to be honest, 18 months is a long time, so I would be thinking, is that normal? Number one thing is this normal? Is this okay? Is there a problem? Is there a foreign body in your nose, or is there a, I don't know, reason for this? Is there a stitch there or something? I don't know. Is there something that's causing inflammation, that's causing it to run more? That's your number one thing. Your number two thing, can anything be done about it? Well, obviously look for an underlying cause and treat the cause. But if there isn't, there are things that you can do to dry up your secretions, There are medication and sprays and what have you can have to dry up the secretions. But I guess if it was me, the first thing I'd be thinking 18 months post-surgery, is there something there that we need to be looking at? So I would go back to your surgeon. That's my advice on that one. I would say not um, it's not normal, and it wouldn't be something you'd want to get looked at, really. This is a good one. This is a good one. I mean, not that the others, they're all good, all right? They're all good. And this is just amongst the good ones. This is one of the good ones, one of the many. So, do you really lose volume by going under the muscle? I want the look of 250cc sizes, but our size is a true reflection of what size I will be after surgery. Now, that is a good question right there. That's a good one. Whew, that is a good one. You know what? It is hard choosing implants. There is no really good specific way that you can tell how everything's going to react, how your body's going to react, how your scar tissues are going to, how your tissues are going to fall. So it is a difficult process to go through. And I don't normally tell people to adjust for having them under or over the muscle. People do say that having them under the muscle squashes it a bit, but I don't think it's to the extent that I would therefore choose a bigger implant. I think it's hard enough choosing an implant without putting that as an extra level of complexity. I think you have to choose an implant based on dimensions. The dimensions are really important. So whilst the sizes are important, what I go in is I go dimensions first. I measure the dimensions of your chest first, and that then straight away gives you a certain group of implants that you will be able to have. You can't have any implants you want. Once you've got the dimensions of your chest, you have to respect that. Secondly, the shape and the profile. Teardrop, round, high profile, low profile, moderate profile, extra high profile, whatever. So look at the photos, different profiles, get an idea of what sort of profile that you would like that will complement the shape of your breast, because you have got to add the implant to your breast. Once you've got a shape and a profile that you want, the width of your breast is set. There'll be a couple of implants that will fit your frame. There won't be a wide variation. So I wouldn't say necessarily, I wouldn't really go for a bigger one to because you're worried about going under the muscle. The sizes is really something to get an idea of what sort of volume once you've chosen the shape and the profile. So the shape and the profile is more important than the sizes, although everybody worries about the sizes. So what I would be saying to you is, look, choose a shape and profile. The width of your chest is set. And then you've got to hope it matches about the sizer of the Type 250 sizer. And if there's one a little bit bigger, you might be feel more comfortable going with that one because as long as it still fits within the remit of your frame. If it means changing profile, if you like the moderate profile, for instance, and the moderate profile implant is 230 or 220 or something, and the high profile implant is 270, and you're worried because you think, hold on a minute, I'm going under the muscle, maybe I should have the high profile because it's going to squish it a bit. I would be worried about doing that. I would be worried about changing profiles to suit this question about the muscle. I think if you were going from if your choice was between a 220 and a 250 moderate profile, both the same profile, and you like the moderate profile, then maybe you say, oh, well, I'll go for the 250 because I'm worried the muscle's going to squish it. But I wouldn't go for a higher profile to affect this perceived action of the muscle. I hope that makes sense. So I would stick with the shape and the profile. That's my trident approach. Yeah. Dimensions first, shape and profile second, volume third, in that order of importance. So don't get too hung up on the volume. Go for the shape and the profile that you want, and then choose a volume that matches the dimensions of your frame. I hope that is, I hope I've answered that okay. What we got here, Olivia's in. Olivia is in. A question. Is hippy scrub wash harsh on your skin? I've stopped wearing my compression. I've not put the antibiotic cream on today. Shall I also stop the hippy scrub wash in the morning? My arm rash is a bit better, but hasn't gone around Brachioplasty wounds. Yeah, I mean, first of all, if someone has given you hippy scrub, I wouldn't want to be the one to say stop using the hippy scrub, because that might be their regime, their post-op regime. But in general terms, yeah, hippy scrub is a chlorhexidine wash, which is antiseptic and is very good because it's antiseptic. But the problem with these washes, and to be honest with you, I don't get it quite so much these days. I used to, oh, hello. Used to get it more when I was in the NHS and doing big lists where you're scrubbing your hands a lot, where you're doing lots of operations. If you're doing sort of an emergency list or something where you've got lots of operations back to back, and you're scrubbing your hands a lot with hippy scrub, it can really dry out your hands and it can really take away the oils in your hands. It's quite harsh in that respect. So it's good that it kills the bugs, but it can dry out your skin, and so it's good to moisturize in between. And just be a bit careful that you don't want to think, oh, I'm going to scrub it and get all these bugs away, because if you, especially with, again, I'm not suggesting you are scrubbing, but if you are really giving it a scrub, certainly if the skin's getting excoriated, if you're getting a rash, if the rash is due to the hippy scrub, you think, oh god, then the rash can potentially have the skin can break because of the rash, and then that can be worse, because you've got broken skin there, which can get bugs in and things. So the reason for using the hippy scrub has been sort of negated by the rash and the thing. So getting the balance right, be a bit careful, but yeah, stick close with your surgical team. I know that might be a problem, but stick close with your surgical team if you can. Oh, there you go. You're seeing your GP on Friday after work at 3:30. There you go. Fantastic. But yeah, got to be a little bit careful with the old hippy scrub, because it is quite a potent antiseptic, which is, as I say, good, but it also can be a bit harsh. Thank you, Olivia. Nice one. What are the different incisions for a breast augmentation? Normally, an implant for BA leaves a scar under the breast. I've heard of surgeons placing the implant through the nipple instead. Is this wrong? Is this right? Wrong. So there's different incisions for breast augmentation, and you're absolutely right, normally it leaves a scar under the breast, inframammary fold. That's the one I usually use, and to be honest, in this country we normally use it. I think you find most surgeons will use that most commonly. The other incisions you can have is the one you're describing, which is through the nipple, which is actually called infraareolar. It's not actually through the nipple. The nipple is the bit in the middle that sticks out. So it's usually a U shape of the areola, which is the pigmented area around the nipple, the sort of brown or darker skin around the nipple, and you make a U-shaped incision at the bottom border of the areola. Lovely incision, usually heals beautifully. Use it all the time for gynecomastia on men. Really hard to see once it's healed. Means no visible scarring on the breast. Fantastic incision. The downside of that incision is that it can interrupt the nerve supply potentially, and the milk ducts potentially to the nipple, because you are cutting through some of the breast tissue when you're doing that incision. So there's increased risk of nerve and problems with breastfeeding after it, potentially. A little bit more difficult because you're cutting through the breast tissue, but nevertheless, perfectly acceptable way to do the surgery. Really look for surgeons who do it a lot, really, I guess. You'll find some surgeons do it a lot and some surgeons don't. America, I think they do it a lot more than we do. Doesn't mean they're right, we're wrong, or we're right, they're wrong. It's just like different. And there's pros and cons. As I say, when the scar heals well, it heals fantastically. If it doesn't heal well, then you have got a scar on the front of the breast, because it's in the nipple, whereas the inframammary scar is a little bit better hidden. The other incisions are armpit, transaxillary, which is even better hidden than the areola one in the armpit. So that's fantastic in terms of scarring, because there's absolutely no scarring at all on the breast or the chest. Problem with that is it's difficult to get a good cleavage. That's the main thing. That's the main reason I don't do it. I've in my hands, I mean, some people, again, in France, overseas, I think in Europe, they tend to do it a bit more than we do. And again, if you get someone who's an expert in it and who's done hundreds of cases and got great results, then I can't argue with that. But you probably wouldn't want me doing it, because I haven't done hundreds of cases. I've done the inframammary approach. That's where I get good results. I like the inframammary approach because you've got direct access to this area here. This area here, the cleavage area, which is really important. The cleavage areas are really important to get those implants sitting right there. and particularly when it's under the muscle. And if you go transaxillary, if you go into the armpit, it's quite a long way to get here from the armpit, and you're blind for a lot of it. You're not doing it under direct vision. I worry about damaging blood vessels in that area, causing hematoma, or just not dissecting it well enough to give a nice enough pocket. Oh, check the nail. To give a nice enough pocket to the cleavage area. So that is my worry about transaxillary, but I totally understand it that the scar is not on the chest. And sometimes people come and say, I want transaxillary because I don't want a scar there. I'm like, I totally get that. And that is a totally acceptable technique, but it's not, I won't do it because I just wouldn't do a good enough job because I don't do it enough. The other one, tuba, TUBA, bit off the wall. Transumbilical breast augmentation, go through your belly button. Yeah, you heard me, your belly button. So you can go through your belly button and then put an implant in the breast to give a scar in your belly button. Crazy, I know. Again, it's an American thing, really. It's because it's a saline implant that you blow up. So you put it in empty, put it up there, and then you blow it up with saline, which is not really something that we do here in the UK. So that's not an option, really. Oh, well, not anyone I know. Olivia's going to stop the hippy scrub. Oh God, I don't get in trouble. Don't blame me, Olivia. I'm just giving you my take on it. I hope it's all right. Here we go. Look at that. Question 13, guys. We're on question 13. We're going to do this. We've got 14 questions. We're going to do this. The end's in sight. Come on. Do the wounds in the armpit take longer to heal / stay red for longer after brachioplasty if compression has also been close to the armpits? Yeah, I mean, one of the things about plastic surgery, we're always trying to hide the scars, and certainly the armpit is a good place to hide the scars, as is the groin, as is the tummy tuck fold. We're always trying to hide scars in sort of crevices and places with shadow and things, and the armpits are classic because it hides the scar really well, but it's just not a great place for a scar. It's just hot, it's sweaty, there's movement there, so it is not a good place for a scar. So yes, wounds in the armpit, particularly if you have a brachioplasty, you often have an L, so it goes down the arm and then L into the armpit. And anytime I say there's a corner, I say with the mastopexy, anytime there's a corner, you've got that sort of point of tissue which can have problems with delayed healing. So yeah, definitely the armpit is often potentially an area where it can take longer to heal, and the scar might be a bit more red, a bit like when you do a breast reduction or a mastopexy down at that T junction. That doesn't heal so well, but the good thing about both those is it's hidden. So although it's horrible at the time, if it's not healing so well, the scar is hidden. So when it does heal, it's usually difficult to see. So that is the reason we put the scar there. But it can be a bit of an issue if it is taking a bit longer to heal. Amanda says, thank you for answering. You're very welcome, Amanda. Thank you for asking. And Olivia, I've got it in black and white, guys. There you go. Disclaimer. She's not going to blame me if it all goes wrong when she stops using her hippy scrub. So there you go. Screenshot that. Thank you. Right. This is a difficult one, isn't it? This one here. Is it the last question? It's the last question. Yeah, this just came in this evening. Thank you for the question. Last question. Oh, God, see my ball bit there. God, dear, oh, dear. Look at the state of that. Woo! Dear, oh, dear. That's a shocker. It's a shocker whenever I go in a lift. Oh, God, those are mirrors. Terrible. Anyway, well, professional, I'm going to rise above it. I'll pick up my nail, though. So, are B-light implants worth it? Hi there. I was just wondering whether I could ask a question for the live feed. My question is, are B-light implants worth the extra money? It's going to cost me an additional £1,000 for B-light implants over Mentor, and I'm just wondering whether it's money well spent with them being 30% lighter, ? God, dear, oh dear. Well, are B-light implants worth it? It's really hard. Is anything worth it? What's worth? It depends on the value you put on it. One of the things about B-light implants is they're relatively new, and I think surgeons are generally anxious about new technology. I think the concept of the technology is good, and I think the concept is a no-brainer. Light. Do you want a lighter one or not? Well, yeah, I'll have a lighter one. The concept is definitely a good concept. I think it really comes into its own for larger uh, sizes, which for me, I don't tend to do the really large sizes personally quite so much. I think the benefit is going to be less for the smaller sizes because obviously the difference in volume is going to be less. Um, I think, is it worth the money? $1 million question. I don't know. I mean, it's I don't know. I don't know if we've got the evidence there. We haven't got. I haven't got any more. You could put one B light in one side and one standard silicone in the other side and say, oh, does one side feel better than the other? Would you pay, extra? It's really hard, and I don't know. And it's one of those things that maybe in 20 years' time they'll all be light, and we will say, God, remember we used to put those heavy ones in. Um, and you say you can have a heavy one, but it's going to cost you 1,000. You're going to save yourself £1,000, and everyone will be going flipping out. I'm not having a heavy one. I'll have the standard ones. Currently, silicone implants are the standard, and B-Light are not the standard. So that is the problem. I think certainly from a surgical point of view, we're a bit anxious about new things, about new technology, and that makes us, well, I say us, I shouldn't lump everybody in, me anyway. My disclaimer, this is just my view, makes me think, so I am a bit like that, and I don't know if it's worth it. We've got one in the clinic. I say, look, that's a B light, that's a standard implant. It is lighter. People can feel it like, oh, it is lighter, but when it's inside the body, I think the difference is less because it's sort of moment effect. Really tricky question. Great question. Love the question, and I'm struggling to answer it because I think, I I don't think any body, never mind any surgeon, I don't think anybody will be able to answer that question with a resounding yes or no. I think it has to be, depends on your body habitus, on your size of implant, whether that might have a more of an effect. And I just don't know. They haven't been around that long, so I don't know. I'd be a bit knackered without your advice, JJ. My Turkish surgeon is MIA. Your advice is invaluable. Thank you. You're very welcome, Olivia. That's a nice lasting comment. Thank you, Olivia. I will do my best to advise, but I do feel a bit awkward. I mean, I'm very happy. I don't mind who has had, if you've had surgery with other people or are going to have surgery with other people. I'm very happy to give you my view, but it is just my view, and I'm very aware that I don't know everything. Nobody knows everything, unless you get someone who's just way off and, way outside the fraternity. I think most people, most plastic surgeons, will have their views, and our views might differ between us. That doesn't mean one's right or one's wrong often. So it's just a question of balancing up getting as much information as you can. That's why I do this, to get as much information as you can, to give you as much information so that you can arm yourself and make an informed decision about whether B-Light implants are worth it, where to have your cyst removed, what make of implant to have. There's no right or wrong answers. I think sometimes it'll be easier, to be honest with you, because I get sometimes people come to the clinic and they say, oh, I've heard these implants are the best. This make of implant is the best. I'm like, well, who told you that? Who told you that make of implants the best? It's usually someone who can only give those make of implants. They're linked to one implant manufacturer and they only use that make. So I think that's a bit disingenuous saying they're the best, because if they were the best, I mean, I use the best. The only difference is polyurethane implants. There's only one make that makes them polyurethane. So I think you could probably rightfully say that Polytech are the best polyurethane implants. They happen to be the only polyurethane implants. But I think for silicone implants, there's different makes, and there's good and bad about all of them. Some people use these ones, some people use those ones for different reasons. Often it's, you have as a surgeon, you have a what's the word, a sort of, well, link or a you know, a relationship, if you like, with the company, with the manufacturer. Sometimes people frown on that a bit, but often surgeons have got relationships with the manufacturers because they use the implants a lot, because they think they're good implants and because they're happy with them. So it's not necessarily a bad thing. Um, uh, but I don't think you can say one is the best, much as they would like you to say, that the implant manufacturers would like you to say theirs is the best one. I don't think anyone can make that claim. I think they're all good. They've all got pros and cons, and you just have to inform yourself. And the thing that I always say is the surgeon is more important. I really do think the surgeon is more important. People get hung up on what implant should I have? Should I have Nagor or Mentor or whatever, polyurethane or teardrop or round, or, you know, obviously these things are important, no question about it, and you should make a judgment on it and be informed about it, but don't worry about it too much, because it's not going to make a massive difference as long as you get an implant that fits your frame. The thing that's going to make a difference is how that implant is placed, where it is placed, you know, the how meticulous about the surgery, making sure that there's no bleeding, making sure the pocket is made right and it's not too high, not too low, not too wide. So those are the really important things. Oh, what's going on here? Amanda's off to watch Bake Off. Oh, am I going off on one a bit? Thanks for answering, says Corinna. Olivia, integrity, honesty. Look at that. Integrity. Yeah, thank you, Olivia. And Amanda's off to watch Bake Off. All right. All right, Amanda. Well, if Amanda's off, there's no point in carrying on, really, is there? Okay, Amanda. Well, enjoy Bake Off. Olivia's off as well. Cup of tea. Right, everyone's off. Is it just me then? All right, I'll be off as well then. Right. Well, thanks for coming. Thanks for bumper cropper questions. Fabulous questions. Oh, she's back. Yeah, yeah. No, Amanda, you said you're off to watch Bake Off. It's okay. It's all right. Yeah, yeah. Olivia said, right, guys, listen, I'm off. I suggest you go and get yourself a cup of tea, bit of Bake Off. I would do likewise. I'm not into it. I think these things have a lifespan for me. The Bake Off, I think, has gone too far personally. Looking for something new, really. But Amanda, you enjoy it, and I will see you same time, same place next week. And please ask questions because I love it, and the more the merrier. And thank you all for asking some fantastic questions this week. And let's go and watch some TV. Good night. Bye.